Good evening, and thank you for all those who are still here after a long, very interesting day. So the topic that I'm going to speak about is responses to CAR T-cell therapy in multiple myeloma, and we're going to focus on BCMA-directed CAR T-cells, where there's most of the data in the last 5 or so years. These are my disclosures. So this is, I think, by now familiar to almost everybody here in the audience. Structure of a CAR T-cell, it has a antigen-recognizing domain, the scFv, that recognizes the target. In the case of myeloma, we're going to focus mostly on BCMA-directed CAR T-cells, although there are other targets in CAR T-cells that are coming to clinical trials. And this is a co-stimulatory domain in CD28 shown here. The other commonly used co-stimulatory domain is 4-1BB, as well as a signaling domain CD3-zeta. And this is the general structure of most CAR T-cells that are in clinical trials currently. Specific CAR T-cells may vary based on the scFv. There's several different choices for each antigen. It may vary on co-stimulatory domain, as I mentioned, CD28 or 4-1BB. And there are other differences in terms of manufacturing, other tweaks that can be done. At this point, there are no head-to-head comparisons of different CAR T-cells for multiple myeloma. So what each of these modifications bring to the table in terms of safety or efficacy have not been directly compared. This is yet another way of looking at it. So in terms of targeting myeloma with CAR T-cells, the earliest clinical data comes from using CD19 CAR T-cells. This was from the UPenn group. Algalfal and colleagues published this 4 years back in the New England Journal. The first patient that was treated with CD19-directed CAR T-cells. This is a patient with relapsed and refractory multiple myeloma. So the rationale for targeting CD19 in multiple myeloma, some myeloma cells express low levels of CD19. Myeloma and so-called myeloma precursor cells. There's regulatory B cells in the microenvironment that express CD19. And I think most importantly, there was a CD19 CAR T cells available. So it made sense based on these rationale to use CD19 CAR T cells in the setting while we waited for other targets and CAR T cells to become available. So this first patient received CAR T cells, CD19 CAR T cell in context of a second autologous transplant. So this was not just CD19 CAR T cells alone, but followed then by, preceded by a second autologous transplant. And since then, 12 patients have been treated, but this patient had what was called as a remission inversion. This refers to the duration of remission after the second transplant, which is expected to be much shorter than the first transplant based on what we know about melphalan and second transplants in multiple myeloma. And this patient had a significantly longer duration of remission after the second transplant, which suggested that perhaps the CD19 CAR T cells added to the efficacy of the second transplant. So since then, this is also now published. 10 patients have received CD19 CAR T cells in the context of second transplant in the study at UPenn. And 2 out of the 10 patients had this so-called remission inversion, including that first patient that I showed and a second patient. The other patients really did not have this remission inversion. So it's an open question if CD19 CAR T cells have efficacy. The Penn group is now looking at it in combination with BCMA-directed CAR T cells in high-risk patients up front, and that'll be interesting to see what the CD19 CAR T cells bring to table in that setting. So moving on from CD19 CAR T cells, there are several different targets that people have evaluated in the lab and now in clinic as well. The one that really stands out and has been now tested in more than a dozen different clinical trials, early phase clinical trials of CAR T cells, is the BCMA B-cell maturation antigen. Again, the first patient was treated at NCI nearly 5 years back now, and since then, like I said, maybe a dozen or more clinical trials ongoing here in the US and outside. So this is the preclinical work from Jim Kokendorfer's lab at the NCI looking at BCMA as a target. So the reason BCMA was picked was it is expressed at high levels in many, if not all, patients with relapsed and refractory multiple myeloma, and very little to no expression in other cells except for mature B cells and plasma cells. This is work from my colleague Eric Smith in the lab looking at mouse models, xenograft models of multiple myeloma that were treated with CD19 or BCMA-directed CAR T cells using one of 5 different scFvs. And as shown here, the mice that were treated with CD19-directed CAR T cells at least did not seem to have much of a response. And 2 out of these different scFvs really had the best pharmacokinetic and and clinical profiles in the mouse. And both of these BCMA-directed CAR T cells are now in clinical trials. So as I mentioned, there's several, I think since we made this slide, several more CAR T cells for BCMA-directed CAR T cells are now available, but this is about 11 or 12 different CAR T cells that have been in clinical trials for the last 5 or so years. These are all BCMA-directed CAR T cells. They differ, like I mentioned earlier on, in terms of scFVs. Some of them have murine scFVs, some human, some actually have llama. They also differ in terms of co-stimulatory domain CD28 versus 41BB. There's also differences in manufacturing for some of these products, and they're all currently in phase 1 or 2 trials, and some of them have early results as well. So this is from the New England Journal a couple of months back, looking at the initial experience and results from BB2121, which is a anti-BCMA CAR T cell therapy in patients with relapsed and refractory multiple myeloma. This was a phase 1 study that was run here in the US. This is the Consort diagram from the study. There were 36 patients enrolled in the study and 33 patients that were treated. 3 patients, unfortunately, couldn't make it to the treatment phase because of presumably because of rapid progression of disease while waiting for the cells to be ready. Of these 33 patients reported, 21 patients were treated in the dose escalation phase and 12 patients in the dose expansion phase. The dose escalation phase had 4 different dose levels. The lowest dose was 50 million, a flat dose of 50 million cells. And subsequent patients were treated at 150, 450, and 3 patients at the 800 million dose level. The dose expansion phase was patients were treated between 150 and 450 million. So this is the baseline characteristics. This is typical for a pretty heavily pretreated patient population. The median number of lines of therapy was about 6 prior lines of therapy. About 30% of patients had extramedullary disease. Nearly half of the patients had high-risk cytogenetics. All patients had, or most patients had exposure to bortezomib, carfilzomib, lenalidomide, pomalidomide, and daratumumab, although there were a few patients in the dose expansion phase that did not receive prior CD38 therapies, but the majority had. So this is looking at the responses. Patients that were treated at the first dose level, which is 50 million, and there were 3 patients, really had modest to no responses. 1 patient who had a PR, but all 3 patients progressed fairly quickly. So this was quickly determined to be an ineffective dose. If you look at the higher doses, the 30 patients that were treated at 150 million or higher, there was good responses, and including deep responses in almost all dose levels. The overall response rate was 85%, with nearly half of the patients, I think 45% of patients, achieving a CR or stringent complete response. As a point of reference, I would point out that in studies of single-agent daratumumab, the early studies, the response rate was about 30%, and the CR rate was about 15%. If you looked at a combination like daratumumab, pomalidomide, and dexamethasone in advanced myeloma, the CR rate is probably about 10 to 15%. So in this setting, seeing a response of about 80 to 85% or higher, including deep responses, CR, stringent CR, MRD negative CR, is certainly quite encouraging. So this is the swimmer's lane plot for this study, and a couple of things to point out. Patients are MRD negative fairly early. The yellow stars here indicate MRD negativity. This is MRD negative by bone marrow only. Many of these patients, some of these patients are in PR or VGPR at the time of MRD assessment. And as you can see, with time, the responses deepen. So for instance, this patient was a PR here all the way up to 6 months, and then subsequently converted to very good partial response with ongoing responses at 18 and 20 months. So there's early response in terms of free light chains, in terms of bone marrow clearance, but the paraprotein, particularly the M spikes, can take quite a while to disappear, and in some patients up to 12 to 18 months before they achieve a complete response by IMWG criteria. So this is, I think, the other important slide, which is progression-free survival. The progression-free survival for the 30 patients that were treated at the effective doses, which is 150 million or higher, was 11.7 months, a little under 1 year. It was obviously pretty short for the patients, the 3 patients that received 50 million or lower, the ineffective dose. This is looking at expansion of CAR T cells at different doses. The peak expansion was, the peak expansion was fairly comparable across the higher doses of 150, 450, and 800 million. And The persistence is variable. I have another slide looking at persistence as well. We'll come to. So this is MRD negativity in patients that had MRD assessments done at 1 and 3 months. And there were 16 patients with adequate samples to look for MRD. And all 16 patients were MRD negative using the adaptive next generation sequencing panel at 1 or 3 months. Suggesting deep and early clearance of the bone marrow in these patients. And the PFS for these 16 patients was about 17 and a half months, so about 1.5 years of PFS for the 16 patients who achieved MRD negativity after CAR T-cell therapy. This is from a poster from Dr. Munshi a couple of years back, looking at the response at 1 month and the best response for patients who have MRD negativity, the 16 patients who have MRD negativity. As shown here, some of the patients at initial, although they're MRD negative, by serology are still only stable disease, and only 5 patients had a complete response or stringent complete response at the time of MRD negativity. That number eventually gets to 11, so there's, again, similar to the swimmer's lane, there's a deepening of responses with time, and it takes a while before patients are VGPR or CR with BCMA-directed CAR T-cells and in BB2121. So this is the PFS slide for the MRD negative patients, the 16 patients, 17.7 months. Looking at CAR T-cell persistence over time, there were 33 patients included, and most patients had detectable CAR T-cells, obviously, at 1 month. Out at 12 months, there were only 10 patients who were evaluated, and 2 out of the 10 patients had persistent low levels of CAR T-cells on this study. So this is a different study, that one that we were associated with. This is the GPRCSD, which is a Juno cell gene CAR T-cell in a similar patient population with relapsed and refractory multiple myeloma. Again, the overall response rate across dose levels and similar doses of 150, 150, and 450 million. We saw an overall response rate of about 82% with VGPR, 48% of patients achieving a VGPR or better. Notable here is that patients treated at the lowest dose level of 50 million also had responses, including CRs and stringent complete responses, including MRD negativity. And the follow-up at the time of reporting was fairly short. The median follow-up was about 11 weeks. So this is the swimmer's lane plot for the 14 patients treated at the lowest dose level, the first dose level of 50 million, and 6 out of the 9 patients who were evaluable were MRD negative, 10 to the power of -5, using the adaptive next generation sequencing panel. And similar to the experience with BB2121, we do see deepening of responses with time, with initial partial responses and VGPRs that over time convert to CRs in at least some patients. So I'm not summarizing the results from all of the studies, but a few key studies that are currently going on as multi-center phase 1-2 trials here in the US, including BB2121, GPRCSD, the LCAR B38M, which is the legend study from China that's currently being run here in the US by Janssen, as well as the Poseida study. And as you can see, the doses are variable, but the responses are fairly comparable. The overall response rate is anywhere from 60 to 90% in these patients with relapsed and refractory multiple myeloma. The CR rates are, VGPR or better is somewhere between 25 to 75% of patients achieve a very good partial response or better. The PFS has not really been reported in some of the studies. Where there is reports, that is 2 of these studies, BB2121 was 11.8 months. The LCAR legend study was about 15 months. To note, the LCAR study was done in China. Many of these patients had fewer lines of treatment. Only 1 out of all of these patients received daratumumab, slightly different population. So it'd be interesting to see how this product looks in a more contemporary US patient population, and we should hear that hopefully soon. The CR rates and neurotoxicity are seen, mostly manageable in all of these studies. A high proportion of patients have CRs, and again, across these studies, most of these CRS is grade 1 or 2 CRS with a few grade 3 or higher events. And the rates of neurotoxicity, again, is relatively low, and serious neurotoxicity that is grade 3 or higher is uncommon, although we'll hear more about it from Deepu, I think. So I just wanted to, this is one of our patients we treated 4 years back, one of the first patients we treated with CAR T-cells, MCARH171, which I didn't talk about here. Very advanced multiple myeloma, refractory to last lines of treatment when we treated her. This was a PET scan at baseline, extensive bone-based and extramedullary disease with rapid progression when she came to to the trial. She barely was eligible to receive the T cells, which she did. And this is her PET scan 2 months later with a complete metabolic response. And she had a VGPR by virtue of having a small M spike that was detectable at the time of this PET scan. She went on to have ongoing response for about 9 months and unfortunately progressed at that point with more disease and had to receive other treatments since. So those responses are obviously very impressive and encouraging, but we come back to this slide, which is the PFS, about 12 months. Although we do see high rates of responses and deep responses, the durability of response is still something that we need to work on. And I just wanted to finish with this one slide looking at what we're doing, what we're excited about at MSKCC, looking for other targets, newer targets, either by themselves or in combination with BCMA-directed CAR T cells. So this is work from Eric Smith in the lab, looking at GPRC5D, which is a target that's present in plasma cells. This is primary patient samples looking at CD138 positive cells that express both BCMA and GPRC5D expression. And this is mouse experiments looking at recapitulating, I guess, in vivo resistance to BCMA-directed T cells. These are mouse models with OPM2 cell lines. 25% of the cells have knockout of BCMA, so 75% of the cells express both BCMA and GPRC5D. 25% of the cells have GPRC5D alone with a knockout of BCMA. So these mice are then treated with CD19 CAR T cells and 2 batches of mice treated with BCMA-directed CAR T cells. And at the time of relapse, these patients are treated again with a second dose of BCMA CAR T cell and a second or a dose of GPRC5D. And as you can imagine, these patients, these mice who relapsed after initial BCMA-directed therapy do not really respond to BCMA-directed CAR T cells because they're mostly GPRC5D expressing myeloma cells, but they do respond to GPRC5D-directed CAR T cells. So this is in advanced stages of coming to clinic, hopefully soon, using GPRC-directed CAR T cells in patients with relapsed and refractory multiple myeloma, and will include patients who have received prior BCMA therapies, including prior BCMA CAR T cells. So I want to thank the Cellular Therapeutics Center and my colleagues at MSKCC in the myeloma service and the BMT service. Thank you very much.